or share a few comments before we proceed. Cynthia? Okay. She's not yet joined the call, but I know at some point she will, and we'll return back to Cynthia at some point during the webinar. We know the relationship and collaboration between physicians and home care nurses can at times be both challenging and complex. As part of our mission to share best practices and look for ways of sharing these with the participants of the HHQI National Campaign as well as a broader audience, we are fortunate today to have with us two very, very special people who have developed a quite unique and special collaborative relationship. The collaborative relationship that can exist between a practicing primary care physician and a home care nurse. Today's presentation, Integrating Home Care into Primary Practice to Improve Patient Outcomes, is their journey of the two speakers, showcasing their communication, collaboration, and lessons learned over the past 5 years in caring for their patients. At this time, I'd like to introduce our two speakers. First, Linda Murphy. Linda is a registered nurse and is currently the Executive Director for Almost Family, a regional home health care consortium. Her current responsibilities include operations, sales, and business development for a 15-county North Central Florida region. Linda became active in home health care as a field nurse and then became Director of Professional Services for Care Tenders Home Health in Gainesville, Florida. In a highly competitive environment, she has had dramatic success in 5 short years with an initial census of 50 patients to a current volume exceeding 60,000 patient visits per year. Linda attributes much of her success to creating a culture of continuing education and patient-centered teamwork in her employees. Dr. Alan Goldblatt is a graduate of St. George's University School of Medicine. He is board certified in internal medicine, geriatric medicine, and hospice and palliative medicine, and has been in active practice for 25 years and is currently the founder and medical director of Senior Healthcare Center at Crown Point in Gainesville, Florida. His caring for patients both on an inpatient level in nursing homes and in outpatient settings, as well as doing home visits, have given him a clear appreciation for the need to organize patient care in a model that avoids the confusion, frustration, and danger to patients that this increasingly compartmentalized system usually entails. As the medical director for Care Tenders, Dr. Goldblatt has worked with Linda Murphy over the past 5 years. At the conclusion of the talk today, I've also asked Dr. Goldblatt, time permitting, to touch on how and where he sees home care fitting in with the medical home model. Following the presentation from both Linda and Dr. Goldblatt, we will have allotted time for questions. As again has been stated earlier, please, as you generate your questions during the presentation, please forward them to hhqi@wvmi.org. Without further delay, we will get started, and I would like at this point to turn the call over to Linda and Dr. Goldblatt.
Good afternoon, everyone.
Yeah, thank you for asking us to speak. I'll begin by expressing my appreciation for that, for our introduction. It is true that Linda and I have worked very well together for the last few years, while she's been instrumental in creating a tremendous resource for our community, and as much as home care, which we in primary care medicine, particularly those of us who are responsible for taking care of elderly patients, are increasingly dependent upon. I'll go over the objectives on the slide in front of you. Our main objective, our main concern actually, in giving people a message about home care is that in private practice or in clinical practice of medicine, particularly involving geriatric medicine, and my experience in the North Central Florida region is emblematic of this, that we see patients in the office for a very short slice of time, and we make fairly important clinical decisions on the basis of a rather brief interview and hopefully a thorough evaluation. But the follow-up or the outcome from whatever clinical decisions we make may not fit into the time frame of when patients are able to come back in to be seen. And in a large rural population, particularly relatively immobile population, given the problems associated with transportation and old age, not to mention the increasing cost of gasoline, we can take advantage of one of the main benefits of home care in having people out in the field who can act as a set of eyes and ears and can actually report back to us the impact of whatever clinical decisions we make. So home care utilization does expand the physician's clinical option. It should expand the physician's confidence in his ability to practice medicine, knowing that he does so in a teamwork kind of a milieu. And we emphasize teamwork in geriatrics at many levels, but home care is certainly one of the more important ones. We have a patient outcome improvement program that Linda has developed, and the other objective for today's presentation will be a discussion of a more recent change in regulatory requirements that have accompanying additional responsibilities for physicians to document face-to-face encounters within a time frame of when patients receive home care. Addressing statistics is, there are so many statistics that we can point to, demonstrating the need for some restraint in the costs of our healthcare system and simultaneous need for improvement in some of the services that we offer that are perhaps less expensive. Looking at both the 2010 Medicare benefit payments pie chart as well as the projected pie chart 10 years from then, we can see that home health takes up approximately 4% of the entire pie. And as such, it represents a relatively low cost, though increasing percentage of cost of the Medicare dollar. And what we would like to see is the utilization of home health services in an attempt to reduce perhaps some of the incredible expense associated with hospital inpatient services, emergency services, and what have you, and functioning as a conduit for information in patients who are going to different portions of the healthcare system, whether they be going to visit an outpatient clinic or be hospitalized or nursing homes or what have you. We see home care also has the benefit in carrying information, functioning as a conduit, thus reducing the costs of healthcare and confusion with regard to the compartmentalization that was mentioned earlier. Those of us who care for older people know that we don't have to ask people where they want to be. Older people, for that matter, everyone we take care of, prefer to be at home. And we bend over backwards in practice, as do the people that work with us, both our case managers and social workers and home care representatives, to do what we can to maintain independence for older people as long as feasible. And given the costs of health care in different milieu, which we'll see on the next slide, you can see that the daily cost for providing health care to an individual, can we get to the next slide, in a hospital is estimated to be $1,500 per day, nursing home $325, and home health approximately $150. Would that we could provide the level of care at home health that would allow a lot of the patients who at the current time feel that they need hospitalization, or perhaps even more importantly, our ability to influence physicians who take care of patients to be able to practice with some degree of confidence, recognizing that that home health care represents a reasonable alternative for patients who otherwise would be hospitalized with any complications. So lower cost per day is important. Lower cost to the Medicare program in general is important to us. And the home health nurses who have the ability to help our patients avoid some of the more common complications, such as medication errors, that often result in what I would consider unnecessary emergency room visits or hospitalizations. The cost-benefit ratio here for home care is dramatic as far as we can see. Now, given the fact that home care seems like such a good idea, and that those of us who practice medicine, and particularly those of us who practice geriatric medicine, could use the help, why would physicians object to the implementation of home care in their practice? And the answer to that probably goes back in part to our training, because I don't recall any effort being made throughout medical school residency or afterwards to formally introduce me to the idea that we practice medicine better when we see the community within which we practice as a team, as a group. And when we look around and we find out who in our community provides services that we feel are competent and compassionate for our patients, we really want to team up with those kind of people. Physician objections, as the slide relates to, is largely logistical. Additional paperwork, additional office oversight, additional employees charged with taking information on the phone from home care nurses and then communicating that to the treating physician. These are all considered additional responsibilities, given the fact that we come to the office to see patients and try to be as efficient and accurate as possible. Some physicians actually perceive of home health care as an unnecessary benefit, or that we run into physicians who are meticulous and thoughtful doctors who feel that the home care industry has been painted with a fairly broad brush to suggest that there's something malevolent about home care or durable medical equipment, or that it's difficult for them to differentiate between the bad actors and the good actors, so they kind of lump everybody into one category. We feel that it's really important for physicians to understand, as I said in the beginning, that the home health care can improve their quality of service to their patients, that home health benefits are not unnecessary. In fact, they represent significant opportunities to provide additional services, such as palliative care services, such as in-home care services. And working with other providers in the community, they allow us to offer a broader repertoire of reaction to geriatric problems in our practice. Home health care agencies are not all alike. In a small college community like we practice in, I would say that there is a handful of home health agencies, all of which compete vigorously for the home health business. But in fact, physicians can influence this competition in a positive way by trying to determine the advantages that certain home care agencies may have in certain fields. We may have difference in skill level in different home care agencies, whether it be for the care of short-term orthopedic patients or more longer-term patients with multiple comorbidities like the elderly patients or palliative care patients. And if we can have a niche identified, then there really is room for more collaboration than competition in the home care arena. And that may be a bit naive on my part, but I really do believe that the best use of home care, the home care milieu, is to find who does what best and to refer accordingly. Hospital discharge planners have a vital role in determining where patients go when they leave the hospital and what, if any, home care is offered to them. This is a role that's often abdicated by physicians because they may not have a knowledge of what resources are available, or they may not care about that particular part of the patient's health care. We feel that it's really important that when we delegate a huge amount of responsibility that has an impact on our patients in the future, that we know who we're working with and we know what the options are. So physicians in practice need to be able to speak to their discharge planners. They need to address the rather confusing regulation that says that patients are allowed to choose their own home health organizations. Obviously, if a patient has been in the hospital, who's in the hospital has been at home and been receiving care from a home care agency and they're happy with that, they should be given every opportunity to go back to that home health care agency. But in the majority of situations where the patients are faced with a number of names on a list of names on a piece of paper and asked to pick the one that they like, the likelihood of them making the most well-informed choice is rather slim. So that also requires that we know what resources are available in our community, we as treating physicians, and hopefully we can lend a little guidance at this point. My own practice here is the Senior Healthcare Center. I've been fortunate enough to work in collaboration with North Florida Regional Medical Center and developing an outpatient geriatric clinic where we have on-site social service and case management services available. We have a geriatric pharmacist who has literally saved our patients millions of dollars a year in cost of drugs with an in-depth knowledge of Medicare Part D and other insurance coverages and what medications work well in different situations, allowing us to provide the best medication that's the least expensive for a given medical problem. All of our physicians at the Senior Health Center emphasize the same, I guess, two main prejudices that we hold in the practice of geriatric medicine. The first one being that, generally speaking, the less pills you take, the better off you are. And the second one being that over time, in the care of elderly patients, their functional capacity becomes really the key objective that we're paying attention to. And if their cholesterol level is a little high or low, that becomes so much less important than their ability to get out of bed under their own power in the morning and go about their daily life.
So at this point, I'd like to, when we were first asked to do this talk, it took me a few minutes really to gather my thoughts. And I actually was on a plane when it kind of came to me, and I thought back over the last 5 years on how we've gotten to the point where we've been able to implement some great pilot studies and programs in our territory. So this is basically, I'd like to paint a little bit of our story, and I think there were some things that we had to put in place in order to get to this point. So I kind of this looks a little bit like Maslow's hierarchy, and that's what I'd like to talk to a little bit right now. But let me give you a little bit of history first. I fell into home care about 8 years ago after a year of cancer treatment, and I worked for a very small nurse-owned and run operation. Absolutely fell in love with home care. I could not believe how we could enact change and collaboration with patients and physicians in our territory. And I worked as a PRN nurse, and let me tell you, I still talk to Patty, who was my boss at that time, and how in the world did you get me as a PRN nurse at $25 a visit to code my own charts, get all my own literature, spend hours at night on the internet trying to find any educational pieces for my patients, but absolutely loved it. But as we all know, home care is not a 9-to-5 job. It really envelops your whole life, and really that's what we look for folks that are really successful in home care. So I came up after a few years, assumed the director role in our Gainesville office, and again, we had a census of about 50 patients if you counted our discharge patients. We hadn't quite processed their paperwork yet. And I do realize how fortunate I was. Dr. Goldblatt was already in place as the medical director of our agency, and I can still remember I had no management experience when I stepped into the director role. And I remember the first time we were meeting him, and my VP and my executive director with me, and I was a nervous Nellie, much like I am today. But at that time I said, as long as I don't have to talk to him, and they said, don't worry, we'll handle the whole meeting. And I can still remember Dr. Goldblatt, as they talked, just kind of put his hand up to say, hold on a second, and turned in his chair around to me and said, okay, so what's your plan for this agency? And I won't tell you what I said at that time because my thoughts have certainly changed from that point. But I did realize that I had to put some building blocks in place for us to be successful, and that's where I came up with these 6 C's. And the first one, of course, was to cultivate, and we're going to talk about each of these. Culture change and competency kind of run together for me. Consistency, communication, and of course the top of my hierarchy is collaboration. So let's talk how we got to that. Cultivation. The first thing I did when I came on is I had one marketer or account executive or patient liaison that worked in our territory, and I hired a good friend of mine that actually had just completed her master's in health science and education through the public health arena. She's actually currently working on her PhD. But she would come in, she had so much energy, you know, she had done her 3rd Ironman, but she was saying, Linda, do you realize how much the community has no idea what real home care is? And she says, even myself going through all the educational programs, and her father was a physician and her mother was a hospice nurse, she really didn't have a clear understanding of what home care was. So our objective at that point was really to shift the perspective of the community at large and work on educating folks, not just consumers, physicians, and the community to what home care is. So we started off with an Ask a Nurse series in all the newspapers and all the senior magazines. We started what I consider educational advertising. We talked about depression, fall prevention, diabetes, palliative care, and patient choice. When we really started trying to educate physicians, educating our consumers, and even our staff members on what we were truly trying to accomplish here. We also looked at access to care. We do live in a very rural area, and I find that where the disparities are greatest, those patients don't have a lot of access to physicians. I can't tell you how many 93 and 94-year-old patients that I'm seeing, and they actually ended up in the hospital under some kind of crisis but had never seen a physician in their life. So again, we started talking about well-being. About this time, a lady from FEMQ, and that was Florida's kind of HHQI that we had that was contracted by CMS, came into my office, and she was amazing. She introduced me to my OBQI results and initiatives. She introduced me to HHQI, and I started to implement those initiatives that they had. And I will tell you, now we were small, so implementation is a little easier when you are small, but within 1 year, we were able to reduce our hospitalization rates from 31% to 17%. We were able to decrease our, the Florida initiatives at that time was reducing rehospitalization and dyspnea, and we were unbelievably successful. I love stats, I love the numbers. It was very interesting to really see how risk adjustment and all the other factors played into the care that we were providing. So I do say this because these initiatives do work, and if you have the time to really implement them, they do make a difference. So that, in turn, started to learn to my culture change. And this was a tough concept for me to grasp. I basically thought every home health care nurse is a good home health care nurse. We're all social workers, cardiac nurses, pulmonary nurses, palliative nurses, endocrine, renal. We have to kind of specialize in all of these different areas to educate our patients the way we need to. But I realized that if our nurses, not all of our nurses can work 22 hours a day, or we're going to burn them all out. So I experienced some great turnover in those first couple of months that I was working here in the Gainesville office, which I never expected. And I do remember even walking into my first staff meeting and saying, hey guys, I was pretty appalled at some of the care that we were providing at that time. And I said, you know, if you're not here for the right reason, I really need you to go find your happiness elsewhere, because these folks don't deserve anything but 110% of what we can give to them. So it was kind of just changing not just my nurses, but our therapy staff as well, from that culture of task-oriented mindset, we're going to go in and do this, to more of that coaching model. And at that point, they didn't call it self-management support or coaching model. It was just kind of our thought process on how we all needed to do holistic care. And I started it off when they would come in, and it was just these what would you do if this was your mom and dad? And that's really been our philosophy from day one. How would you care for this patient if it was your mom and dad? So I did start to establish that we need to give our staff tools to succeed, and that's where those care pathways and clinical protocols and specialized programs come into place. Figuring out, as a manager, how we inspire our staff to be the best that they can, but we have to have those tools in place to allow them to give 110% of them and the patient's benefit. Competency kind of goes along the lines with this, and you really have to start from the very beginning. Reevaluate your hiring processes. I use the example when I tell folks of the therapists that I like to hire. You have a class of physical therapists and they're just getting ready to graduate, and you ask how many folks are going into orthopedics, and maybe half of the class will raise their hand, and how many are going into sports medicine, about another third of the class raises their hand, and then they'll say how many are going into geriatric medicine, and you may have 2 or 3 people raise the hand. Well, those are the folks that we want in home care. Those are the folks that we want taking care of mom and dad. We started doing group interviews. We have usually a 3 to 5 interview process with everyone. It's a team decision. We do a first interview usually with our director or whoever is hiring for that position, and then all the members that are involved with working with that patient come for the second interview, and we do a team interview. Our third interview is actually pretty interesting. The applicant comes in a group interview, and we usually do some kind of activity that requires them to function in a group setting so that we can see how the people actually interact with each other. So by the time we're done with our hiring or our application process, we really hope we've seen the true person that we are inviting to join our family and our group. And then, of course, incorporating your values at that point and on through. But you'd be surprised how quickly the group that interviews those folks and are responsible for hiring that person mentor them and want to ensure their success. If you look at any organizations, I think professional growth is more important than anything. I know that is high on my priority list. So providing education on hire and ongoing. I recently had an OT that was working for me for about the last year, and I was so proud when he came to me one day and he said, you know, I worked in the hospital setting for 10 years, and we're here at the University of Florida, and he said, I have learned more in the last year here working in home care than I learned in the 10 years in the hospital, and that's the type of environment we really want to provide. As you get larger, you can add some staff members that really have some specialties like WONCs, your dietitians, your palliative nurses, oncology nurses. I think we have to have clinical ladders to retain and promote those clinical expertise. We need to stay abreast of evidence-based practices and by going to conferences and knowing what's out there and what are the best practices to put in place. We need to recognize resources. Again, we're at the University of Florida, so I've been very fortunate to use graduate internships. We've brought on some pharmaceutical students. We actually had some internships a few years ago. We've done a couple. Usually each year I bring on a couple of interns, and you can get these guys for very cheap, sometimes free, but we were able to establish a caregiver support group. Back in 2006, we started a telehealth analysis of data to decrease hospitalizations, so it was very interesting to get some of those items done. So you've gotten to this point, and we all know that we have to be consistent in what we provide, and again, knowing harmony is consistency, and knowing consistency is enlightenment. So when we're all working together and all on the same line, I think we can achieve great things. So we've all become this great organization. We've got great outcomes. We're home care elite. We're doing all these wonderful things. But how do we communicate that back to the physician? And that's really the big question. And about a month ago, I was on an airplane heading up to Kentucky, and there was a lady sitting next to me, and when I was talking to her, and we were telling each other what we did, and I said I was a home care nurse, and she said, oh my gosh, you guys are the best people in the world. She said, I'm actually heading back up to visit my mom, but I was there for almost 3 months last year. She had had a stroke, and she went on to tell me everything that had occurred. But her point was the home care nurse, she said, was invaluable to her. She said her mom had been with a physician for most of her life, and she came out of the nursing home on 36 different medications. She was depressed. She was having a really difficult time getting through anything. She said when the nurse came through and assessed the issues, she said it was really interesting to watch her develop a relationship with the physician and with the physician's nurse on the phone. She said, but when we first started, she said, I really think, you know, some of these medications we're taking because of the side effects of other medications. And she was trying to communicate that with the physician's office. So one day she said, I'll tell you what, why don't I go with you on your next appointment? And this lady sitting in the airplane was like, I had no background on medications and didn't know how to communicate to the physician. But she said, my home care nurse actually came to the doctor's appointment with us, and we sat down and went through everything, and we were able to decrease her pills from 36 pills to 8 pills. She said, my mom is now independent because she can take the medications herself. There was no way that she could do all those beforehand. And the physician was thrilled, and she says, actually, I called her to check and see how she was doing, and she was saying that physician is now one of her best advocates out there. So, again, go ahead.
Well, I would just add at this point that as far as the physician motivation with regard to this whole collaboration with healthcare idea, physicians in general practice are really looking for positive patient outcomes, and we have well-defined patient outcomes. And when we have a patient come into the office and comment positively about their interaction with a home care agency, that really goes a long way to not only make us feel better, but it increases the value of our practice. I can remember, which to me, the most significant home care interaction that I had that I think about in terms of the ability to avoid unnecessary treatment and hospitalization came just about less than a year ago when I was on call and I was called about a patient of mine who suffered from mild cognitive impairment and had recurring symptoms of pneumonia. And we had been through this many times in the past. And at 10 o'clock on a weekend night, the wife called and she explained the symptoms that her husband was having, and he was relatively immobile. And they had expressed a desire to never be back in the hospital if there was any way that could be avoided, which is what we hear all the time. And I was able to make several phone calls and arrange to have a visiting nurse come out, see the patient, have intravenous antibiotic therapy, breathing treatments, oxygen, and the works. It was taken care of within several hours in the patient's home, and he recovered to the point where he was able to regain his previous level of function. But certainly as a physician on call, being called with a problem like this late at night, it would be much easier to say, take the patient to the emergency room. And it requires a mindset that is geared to keeping people at home in order to, and a tremendous collaborative relationship with a home care agency or several home care agencies to be able to affect that kind of change in your practice. And that creates tremendous loyalty for physicians with home care, for patients with their physicians, with families with the physicians. These kind of moments really make the whole system seem like it works correctly. And with regard to the comments Linda made earlier about the philosophy of education that she has around this office, it's very much evident in discussing patient problems with nurses or therapists that the degree of expertise is really phenomenal. And the fact that people stay in a job like this for a long time, the only reason people really would be motivated to do that, given the options that are available to them now, is if there's something more valuable than a paycheck at work. And I really think that her initiative in continuing education at all levels of the organization is what allows her to keep the best people in place. So.
Yes, we've been very fortunate. We have a waiting list for full-time nurses and therapists now who has a waiting list for therapists in their territories. And I think because of the programs that we've been able to implement here through our corporate structure. But also getting back to painting, again, we have to continue to bridge that gap. We have to do it in multiple different ways. And, of course, bringing back our evidence-based outcomes to our physicians so they see that we're truly doing something here in the homes. I say painting the picture, and I have great respect for PTs and speech therapists, but quite honestly, I probably utilize OT in our territory higher than any of our other therapies. It's amazing what a good occupational therapist can do for our geriatric population. And we have a living life to the fullest presentation that my 2 OTs do, my rehab manager and my another phenomenal OT that I have in our territory. But we try to take that to residents, we take it to med students, we take it to medical societies, and we present so they can really see the picture of the changes that we do. And we do it through case studies. We basically talk about these patients and what we've been able to do this. And again, we've got some great pictures of an MS patient that was bed-bound for 3 years and how we were able to get her back using a mobility, and she's out riding the bus now. And those kind of impactful changes, and when you bring those stories back to the physicians, I think that's really what starts to change them from satisfied to our loyal partners. Again, also with your patient liaisons, they need to come to case conferences. They need to bring those hero moments back to our physicians and to those offices so they really see the picture and they understand the value of what we can do. And again, like Dr. Goldblatt said, there's nothing better than when your patient does come back and tells your physician about what a great job we're doing. So the top of our pyramid, we've gotten to that point, and we actually can have that collaborative relationship. We recognize that between all parties, between the patient and the physician, our multidisciplinary team, and particularly between us and our medical director in our territory, we've really been able to establish some programs that I feel are raising the bar in our territory. And when we raise the bar and competition all raise the bar, who benefits? And it's the patient, and that's really what we want. We've been able to do a palliative pilot study. We have transitional care programs, behavioral health programs. We've had a couple of different pilot studies along the way, but I'd like to, I think basically they've given us the ability to implement best practices in our territory. But I'd like Dr. Goldblatt at this point to talk a little bit about our palliative pilot study that we started about 2 years ago.
Yeah, 2 years ago we started a program based on literature that we had been following, both with Kaiser Permanente and other collaborative institutions, where they depicted a model of home health care for palliative care patients that involved providing routine home care, such as you would with any elderly patient who had several different illnesses and or disabilities and they needed the services of a visiting nurse or a therapist, what have you. But in addition to that, we had extra components to this program, which included mandatory visits with, well, the initiation of the palliative care project began with explanation to the patient and to the patient's most, I guess, valued ally, what exactly palliative care was. And for us, we defined it as a recognition. And this was more than just words on a piece of paper. We recognized the idea that patients who are aging and who obtain and who develop a number of different illnesses reach a point in their life where they really don't foresee curative medicine as creating the best benefit. And our goal is to do an excellent job of symptom management, of pain control, of nausea, shortness of breath, what have you, of mitigation of symptoms, with the idea in mind that we don't have to work every problem up to its maximum conclusion. And if the patients understand that they actually are being given the reins, that we're there as consultants and to help, but we ask the patients how much health care they want, and we provide that much and no more. This allows the patients to really, patients and families, when confronted with the idea that their physician is going to be there to listen to what they want and that this home care team is put together in order to provide the amount of care that they want and no more, immediately become much more relaxed with whatever their illnesses are. And we address advanced directives early on in the course of the process. We provide care that's, as I said, geared towards symptom management and improvement in functional ability. And it's not a great deal different from the routine home care that you would normally provide. But our goal is to adhere to what patients want. So, for instance, a large number of patients that we take care of who have exacerbations of congestive heart failure, which is the most common cause of rehospitalization in Medicare patients, if we have home medications available for them to take in case of an exacerbation in the middle of the night, and if they have a phone number where they can call a nurse who's trained to manage this sort of thing, and or their attending physician, and be talked through the administration of medications, oxygen, what have you at home, these patients have a fairly good chance of reducing their symptoms to a point where coming to the hospital is no longer considered necessary at that time. One event like that not only saves the medical system altogether a considerable amount of money, but it also empowers the patients to know that they have some ability to impact their own symptoms. It makes family members realize that everything does not require a call to 911. And working in collaboration with visiting nurses, we can provide a tremendous level of care to patients with the idea in mind that we are not end-of-life, this is not necessarily end-of-life care, but we have a mutual agreement that optimal medical care at a certain point in time is not geared towards perhaps working up every medical problem to its most clinically demanding answer, but that we try to reduce the use of tests, we reduce medications, we aggressively pursue managing toxic symptoms, and we empower the patients. And this has really gained a foothold, and perhaps it's become so, the pilot study using data collection that was already prescribed by
Missoula tool. We use the Missoula Vitus tool.
Missoula Vitus tool, right, allows us to go back and check and see whether or not objectively we're accomplishing what we want, which is generally increase in patient satisfaction and a reduction in unnecessary hospitalization. And we've been very impressed with the results of this palliative care program.
All right, as I look at the time and see that we probably need to be moving on a little bit, so I was just going to address a little bit on face-to-face regulations. And hopefully everybody on this call is well aware April 1st has come, and that all patients must have a physician encounter within the 90 days prior or within the 30 days afterwards, and that has to be documented. Spring training is over. April 1st has arrived, and our industry didn't get that change. So at this point, we really all need to be on the same page as an industry. There has to be a positive presentation to help our industry get this accomplished the way it needs to be. Education of our hospitals, our case managers, and ultimately referral forms that include the face-to-face documentation is what we need to do. Again, we've talked about this collaborative relationship. The only way to be successful in our industry is have a collaborative relationship with our physicians. So we started off basically with asking our physicians some questions and see how they want to handle this. You know, we talk about if there are some patients that you have not seen in the last 90 days, do you usually see them in the office within 30 days? And do you have any problems with our staff calling and arranging those appointments? Do you have a designated contact person? Do you have a visiting home care physician? We don't have that many options in our territory for visiting home care physicians, but I do know in a lot of the larger cities and a lot of areas this is a growing practice. So again, ask your physician, do you have someone that you preferred that if you're unable to get them back into your doctor's office, would you be okay if someone were to see them in their homes? Hospitalists, we all know that we can use hospitals to document this piece as well. Some of our physicians do have hospital privileges, but I find a lot of our primary practicing physicians give this over to hospitalists?
Yeah, this transition is a little bit dicey too, because we want the physician who's primarily responsible for their patient to be involved in the home care documentation. By the same token, having hospitalists fill out this kind of form may or may not appeal to physicians in their own practices. On the one hand, they don't want to feel dumped on by having to do other people's paperwork. On the other hand, we want them to have an active role in the certification process. And I can tell you that physicians' perspective with regard to compliance with these regulations is basically that the regulations, in as much as they would like home care not to be an automatic order that physicians have no responsibility for, we see the need for some regulation. But documentation of encounters with patients that include all the data that's already present on the ubiquitous 485 form seems redundant. And the fact that having to write things out by hand in an era in which we're trying to automate as much as possible and use electronic medical records where possible seems to be counterproductive. And so we're perplexed somewhat by the need for this new kind of documentation, and we would like to suggest that, you know, for hospitalization, for nursing home admissions, for ordering diagnostic procedures, et cetera, there is no need for this additional handwritten documentation. And because all the information is already available on a form, with the possible exception of the date of the office visit, we would appeal to decision makers, and we would appeal to fellow physicians to mention to their congressmen or their state and county medical societies, people who are interested in this initiative, to appeal to their legislators to change the regulation to allow us to continue to document the need for home care, but to do so in a manner that's more conducive to the way we are modernizing our practices, our electronic medical records, et cetera.
So for the time being, what are the items that we need to incorporate in order to meet the regulation? And as we know, it's the encounter date, our medical conditions, our clinical findings, the services needed, our homebound status, and the physician's signature. So in just going through these very quickly, we understand, you know, what's the date that we need to put on this. And I think this is what we taught to, how easy it would be if we could just incorporate the documentation of this date on our 485 on the face-to-face encounter. Medical conditions or diagnoses, and basically those conditions that are specific to the home care orders. Clinical findings that support the need for home care, and I've just put a little bit of a list up here of some of those examples of clinical findings. Surprisingly enough, we would think that this would be an easy form to fill out, but a lot of times it's not quite as easy as we think. We're used to the language because we write, you know, we do 485s, but educating our physicians or those responsible for filling out forms for our physicians, it sometimes can be quite challenging for those folks. I use Dr. Goldblatt's office, for example. He has a social worker that writes up the referrals for the physicians, and there's 4 geriatricians in that office. And when we first had the new reg, and I was talking to Cheryl about it, she said, I'm spending half of my day just writing out these addendums and forms for face-to-face documentation. This is crazy. And, you know, how many of us, I think, are dealing with that fact? I had one of my patient liaisons was in an office up north this past week, and when she went in there, actually the MA in the office had filled out the face-to-face documentation, and she was getting the 485 signed. And when the physician saw that the face-to-face was filled out and he was going to sign it, he said, no way. He tore it up and said, the other agency said I can just attach my H&P to this form, and that's what I'm going to do, and I'm not, you know, filling out another form. And again, it gives us the opportunity to come back and communicate and try to educate, but there's been a lot of pushback from our physicians out in the community, and I think the reality of that situation, we've implemented this regulation as of January 1st, so we've had 4 months of experience in implementing it, but we all need to be on the same page. We all need to be, I know the interpretation of the law is pretty frank, and the questions that have been put in there, but we all need to abide by those regulations when they are in place. homebound status, I think this is a wonderful opportunity for us as a group to re-educate physicians on what homebound status is, the key factors in consideration in making a medical determination of homebound status. You know, do they have a medical condition that restricts their ability to leave their home without supportive devices, such as crutches? Do they need special transportation or the assistance of another person? Would leaving their home be medically contraindicated? Again, it gives us an opportunity for education, guys. You know, if we want to look at the glass, you know, half full or half empty, it's our perspective, and I think in order as an industry to work together, we all need to be on the same page. I did include an example of our fax referral form because I think most folks have a referral form that includes all of this information is basically what you get on a referral form. So if you can come up with your own referral form, and feel free to use these, that include the 5 components, I think it'll be a lot easier on our physicians. So other possible solutions to this also is acknowledge their frustration. The first thing I did with Cheryl, who is our, our account executive, did is to acknowledge that frustration. I can only imagine how hard it is with all the other paperwork that they have to do in their office to add an additional paper to do, addendum to do this. Assure them that the value of what we provide is worth that extra effort. Assist them with developing forms from for the hospitals to use or within their own offices. Show your physician representatives where the information can be obtained on the 485 for references so that they understand the language and what needs to be incorporated in the regulation. And, it is acceptable for the physician to dictate the face-to-face encounter form. At this point, again, I'd like to say I realize how incredibly lucky I am to have Dr. Goldblatt to work collaboratively with, and that we certainly wouldn't be in the place that we are at this point to really have some great practices. Dr. Goldblatt and I have had the opportunity to go out on Sunday mornings and do some in-home palliative care consults as we've tried to develop our program and figure out the best ways. And I can tell you, in my career, those were some of the best moments that I've spent providing patient care. But I would like him to talk to this slide, which is our words out of his own mouth.
Well, out of my own pen anyway, but they can come out of my mouth. But I just, in writing about home care for another publication, I pulled out this paragraph about the collaborative effort of ethical healthcare organizations in our community. All things seem possible, and that is true. We're fortunate to have a university nearby. We have an active private practice community. We have a lot of initiatives towards improvement in healthcare in our community. And the disparate and at times competitive models of academic medicine, private practice, in an era of dwindling resources cannot clearly be sustained. So optimal care strategies for the elderly requires attention to transitions with declining functional capacity with aging. I allude to the medical home model, which deserves greater attention. And with that, home care becomes a crucial part of our management armamentarium. And so I really appreciate, speaking for myself, I appreciate the opportunity to participate in this kind of a forum because I really believe that to the extent that we can provide some pragmatic advice for our colleagues and we can become more popular with our patients at the same time and we can reduce the cost of medicine while improving the quality of health care, I think all these goals are very achievable. And I think home care is an important part of that. So thank you very much.
And just for those on the call that on a weekly basis, I get to expand my English vocabulary, and that last word has become our word of the week. Deb, who's in my room, my rehab manager, loves the word. She's told everybody she knows. But Dr. Goldblatt, so you would give the definition of that word for everybody.
If I don't have a word to fit the situation, I allude to my favorite poet, Ogden Nash, and I make one up. But well, we have a number of different strategies for providing optimal care, and that's what I was alluding to in that last sentence, and I won't make Linda spell it. But thank you.
Thank you. I guess we can open for questions now.
Well, Linda and Alan, on behalf of everybody on the call, thank you very, very much for just an unbelievably exciting and special presentation. I think at this point we are ready for questions. I know that we're a little past the top of the hour. We're going to remain on the line and take questions. So for those of you that are able to continue to be with us, certainly please go ahead and send your questions to hhqi@wvmi.org. We'll take as many as we can. For those of you that can't remain on the line, again, as a reminder, this webinar is being taped and archived, and both the audio version as well as the slides will be able to be viewed probably after mid-afternoon tomorrow. So without further ado, Shannon, I think we're ready for questions.
Okay, thank you so much, Dave. Our first question comes from a participant named Amy, who asks, what is the tool that was used to evaluate the palliative care program?
Okay, I can answer that. First of all, the genesis of the palliative care program, do we have the article? Was based on an article demonstrating a reduction in improvement in patient satisfaction, Linda will find it, with the use of palliative care added to a home care service. And the specific tool that we used, which is available, is called the Missoula Vitus Quality of Life Index, which is
They have a 15 or a 25 question. It's all available. It's free on the site. You just have to log in, and you just give them your documentation or your results for your for each of your surveys or questionnaires. It's a wonderful graph system. We do it every 30 days with our patients. We do it on admission and then every 30 days afterwards. And it measures basically symptoms, functions, interpersonal well-being, and transcendence. But it's a wonderful tool. We meet on a biweekly basis with Dr. Goldblatt, and we case conference all of our patients, so we'll have these results and our graphs also as we go through what we're doing with our patients. We also have a whole team that's very specific to palliative care. We find it much more successful that way.
We can leave the reference for the article that we developed our program around. I guess before we sign off, we'll have the references. Is that okay?
We have another question about palliative care. This one's from Catherine, who asks, how is palliative care reimbursed?
Okay. I can address this, I think, because to the extent that palliative care is reimbursed through home care evaluation and management services, which are used for the frail elderly, and Linda can speak to the industry perspective on this. For physicians, palliative care is not reimbursed any differently than other primary care physician services, whether they be in office, hospital, or home. Although proper coding by physicians is necessary in order to capture the correct reimbursement, and palliative care by nature requires longer conversations and a little bit more patience with a C, a little bit more setting up strategies to allow in-home patients to know what to do in a certain situation. So the physician reimbursement I can speak to is the same as any other home care reimbursement or outpatient or inpatient reimbursement.
And again, we're getting these patients on the home care perspective. I think she's trying to wonder, it's just regular home care reimbursement for the exacerbation or the disease process that we're actually in there treating for the patient. We have a tendency to have a higher visit count with these patients, so again, margins probably aren't as high, but our outcomes are very good, and we're taking great patient care of the patient. A social worker is a key factor. We have a full-time social worker in our area, so they're part of this team that sees the patients as well. So your reimbursement, your margins probably aren't as high on these patients, but I feel it's the care that we need to provide, and as an industry, if we don't start providing that kind of care, we're not going to be able to bring outcomes back that make a difference.
It's also important in a program like this to have a good working relationship with your local hospices or hospice organization, because there are times during which there needs to be a transfer of care, and that should be a smooth handoff, if at all possible. And so I guess I'm going further afield from the question, but
we partner very closely with our hospice in our territory as well, and so the whole purpose of this is to transition patients to hospice when the time's appropriate, and that it seems seamless as well. So again, I think you have to have a really good working relationship with your local hospice for this program to be truly successful.
Let me just add one other point, and that is that the constraints that hospice Medicare presents to patients in terms of their ability to access therapy, when we feel that additional physical therapy or occupational therapy will lead to improved, if temporary, outcomes, if patients are in a hospice program prematurely perhaps and they can't access those services, I think we lose an opportunity to provide the best quality of care. So.
And our program really grew through the ALS Association. We had several patients that we took care of, and again, I have to say we have some tremendous therapists that work in our territory. And the head of the ALS Association for the state of Florida had actually approached us because of the care that we had provided, and that actually kind of really helped our program grow even more in its development piece, because we understood how difficult those patients are to care for and how many services they really do need. But I have a sense that a lot of agencies will tend to shy away because of the difficulty and the expense and all the other pieces it takes to take care of those patients the way we need to.
Our next question comes from Maureen in California. This is a two-part question for you, Linda. Her first part asks, is Care Tenders Medicare certified? And her second part is, are your nurses part of a union?
First, yes, we are Medicare certified, and no, we don't have a union. And we're part of the, our Care Tenders office is part of the Almost family entity.
Our next question is from Brenda, who asks, what is the clinical pathways that you found most helpful?
Well, those, to be honest with you, it depends on the program that we're running. We have clinical pathways now for many, whether it be COPD, CHF, our oncology program, our palliative program. I think the point, in fact, was just that in order to make our staff members successful, clinical pathways help to keep everybody on track on what needs to be done, and helps make us accountable for the care that we're providing. So those can be, I have some that are very extensive, I have some that are short. It all depends on what the specialty and what the program or what we're trying to achieve with that patient.
But which one would you say?
Of course, one of my favorite is our oncology program, but you have to remember I'm a cancer survivor, so that will always be close at heart. But I give an example where I went out on I still do patient care every once in a while. I think it helps keep me connected and understand what our staff members are going through, and especially when we have new paperwork, it helps you really if you do it up front. But a few years ago, I was out on a Friday evening, and it was my first encounter with a patient, and she was a young 56-year-old lady that had esophageal and lung cancer. And she had gone through, I was just there for a 5FU takedown, and this was a private pay patient. But she was going through a huge organization. She did not have she had an oncologist, but she wasn't even sure who her oncologist was at that point. She was in denial. The family was in denial. It was 10 o'clock on a Friday night. She hadn't eaten for 3 days. She had been going through radiation for the previous 5 days. The only drug she had in the home was Compazine. She was going to end up in the emergency room. She was sick as a dog. Last place that an immunocompromised patient needed to be was in the emergency room. So at that point, I thought, wow, we need to do something to provide better care to oncology patients. And that's when I started. I went through chemo certification, and I was like, wow, I didn't know what a neutropenic diet was. I didn't know the side effect of this. Well, I went through 8 months of chemo, and I'm a nurse. So how do we expect our poor geriatric population to know some of these things if we're not better educated to teach them? And in the 5 or 15 minutes, when you have Benadryl and everything else on board, you're not able to really accept or understand what you're being taught. So I think the home is a perfect venue for that education. And their outcomes are better in the long run.
Next, Paula asks, I've rarely done a third interview and think that it's an excellent idea. What types of activities do you do during this group interview?
It's a good question. Actually, I laughed because we recently hired a new clerical person in our team, and I walked into the office when my DPS had the whole team of clinical managers in, and they had narrowed it down to 4 candidates. And they had this group interview where the 4 of them had to build a tower, and all they had was newspaper, tape, and the tower had to hold a cup with coffee in it, and it had to be like 18 inches tall, and they didn't have a measurement, but it was quite interesting. There's lots, if you go on the internet, there's lots of different activities. This is a really new way that a lot of companies are starting to use to interview, and you can see the interactions between the groups and how they're going to interact under pressure. So that was the last one that I saw, but I know that we have in each of the offices, our DPSs have different ways that they like to implement that third interview.
Next for you, Linda. Oh, I'm sorry, go right ahead.
The other piece of that I really love is doing PIs or personality profiles on our management staff, and sometimes even just on staff that were coming into the office. If anyone's had the opportunity to do true colors, which is another way of looking at different people's personalities, we were able to do that with the entire team. And it's really pretty interesting when you learn who your blue folks are and who your gold folks are within the office. And when you understand where people are coming from and what their personalities are like, you can interact and work together in a much more collaborative relationship.
Our next question is from Lucy, who asks, do you think all chronic care patients would benefit from a palliative care consultation?
Dr. Goldblatt, would you like to answer that?
Well, I guess the answer is a qualified yes. I think that the concept of palliative care as defined as the management of patients with active, progressive, or far advanced diseases for whom their prognosis is somewhat limited and the focus of care is quality of life. That definition appeals to me in dealing with elderly patients with multiple comorbidities. So I guess the answer to the question is yes. I think that in an ideal world, palliative care would not stand out as an exception to routine care, but would be incorporated in everybody's thinking as we age and as we see the necessity of living with more and more age-related medical impairments. Some things we need to try to treat, and some things we need to learn to cope with. And giving, I think in terms of the relief I see on people's faces when you tell them that they don't have to have another colonoscopy or another barium enema if they don't want it. I think the idea of empowering patients that have multiple medical problems and a lot of experience with the current healthcare system, I think that the advantages are much broader than just good patient care. I think you provide a better milieu for the way people think about their own health. So I guess yes. Next.
All right. Our next to last question comes from Ruth Ann in Pennsylvania, who asks Linda, first of all, she comments that she likes the phrase hero moments. She wants to know, what if you can't get your foot in the door to share these? She adds that she agrees that the actual practice of the nurse working with a physician to keep a patient at home will make an impact. But she asks again, how do we share this with others? To win their support or garner their interest?
And that's very tough. I'll give you an example. Even just a couple of weeks ago, I had a nurse that was really trying to get some antiemetic ordered for one of her patients that she knew was going downhill and was going to end up in the emergency room. Made multiple calls to the physicians, couldn't get past the MA. And she knows in the end, when she did finally get an order from the MA that said basically, no, the physician doesn't want to do that, she was like, and mind you, she's an English nurse and very outspoken and married to a physician, which I think when you're married to a physician makes you feel like you have the opportunity to say more. But she said, could you put him on the phone right now so I can talk to him? Well, I'm not quite sure that that was expressed as well, but of course he was very upset by that. But her and I, you know, we decided let's go over and let's sit at the doctor's office until he'll talk to us face to face. Sometimes you need to do that. And like I said, even I can't tell you how many times I've gone to a physician's office with my patient because we really felt strongly about what needed to be done. I haven't, even recently I had a moment where I had a patient that was very tied to her occupational therapist, and they had some cognitive impairment, but when they went into the physician's office and the physician went to order something, the patient said, hold on, I've got to check out with Sunshine to make sure that this order is okay. That's not what we want our patients to say, but, you know, and I actually had to go in with my occupational therapist and sit down and talk with the physician. That's, of course, no way that we'd want to present. We're a collaborative relationship. But these patients do become dependent on us a little bit and really do respect our opinions because we have made, hopefully, some significant changes in their lives. So all I can tell her, I know that's difficult. Sometimes I have sat with my marketers for 3 and 4 hours in a doctor's office waiting to talk to a doc that I really feel I need to talk to and be impactful. We're starting a new a thing in our area where Dr. Goldblatt will, you know, we're going to have dinner with some physicians on a quarterly basis, and especially those physicians that I sometimes think don't quite value what we're doing, and I'm having some difficulty getting the point across. I can tell you that I have used Dr. Goldblatt when all else fails. I have had Dr. Goldblatt call a physician or two and say, could you help me? I can't get him to understand this point for this patient. And again, when our objective is really about good patient caring, doing the best for our patient, it eventually comes across.
Our final question comes from Woody, who says that he would like a recording of this webinar to play at a multi-provider meeting that he has every month. Will a recording be available of today's session?
We were led to believe that there might be one available, right? Won't this be archived, this webinar?
Dr. Winter, I think you're on. I think this will be archived and available, correct?
That is correct.
Okay, that wraps up the Q&A. Dave, if you'd like to deliver today's closing comment.
Thanks, Shannon. Again, on behalf of all the participants on the call today and the Home Health National Campaign team, I really would like to again extend our appreciation to both Linda and Dr. Goldblatt for this very, very informative and really very beneficial presentation. Please, we'd like to encourage all the participants to visit the website for the national campaign. That website, again, is www.homehealthquality.org. We're currently working on our next webinar, and actually I've already made some notes. I think it would be a great idea to have both Linda and Dr. Goldblatt again just for a Q&A period because this information is so valuable and their experiences are so positive and just really get to the heart of really what we're all about, which is taking care of patients. Again, as I mentioned earlier, today's presentation, including the slides, will be archived and available to be downloaded from our website. This should be accomplished by mid-afternoon tomorrow. Thanks again for your participation today, and we at the National Home Health Quality Improvement Campaign hope that the rest of your day is a great one. Thanks again to all.
Thank you.